morning, and thank you very much for the invitation to come here and speak. Anyone who's interested in writing a book, I would just say if I can do it, anyone can. And it's absolute passion of mine is to try and understand what it is that we need to do in the space of leadership. And this word called culture that we keep hearing about. Just a little bit about me before I start is I've just recently completed my PhD, which I did last year. And my subject area was trying to understand what this whole concept of well-led means. And I went into an organisation that had been assessed as well-led. And my kind of purpose of the research is, can you define it, can you bottle it, and can you spread it? You know, what's going on here, and what could we do, and what could we learn? And I think, you know, a lot of what I've learned, and if you look at the history of what's gone on in the NHS of the last few years, and the number of big inquiries that we've had, every single report talks about fix the leadership, fix the culture, fix the leadership, fix the culture. And what I'm really interested in is the how. How can we help organisations on that journey, on that roadmap, how to do it, rather than keep telling them to do it? What does that look like? And my experience with this particular organisation that I spent quite a long time with, it is very interesting, and I'll kind of come back to you with a few of those points about why that led to this piece of work. The other thing I really wanted to say to people is I've worked for many organisations, and certainly I think someone asked a question earlier around meeting with families and talking to them when things have gone wrong. You know, it's always the right thing to do. Don't seek permission to do that. That's what we should all be doing. When I was a director of nursing and we received complaints, the easiest and simplest thing to do is invite families in to hear their story. Because quite often that complaint letter doesn't really tell you what they wanted to know. They want to hear and they want to understand that you're going to commit to do something about it and learn. The other point is what I call the small things are the big things. And we're all patients, and we're all families of patients, and it's not us and them. We are them and they are us, you know, that we have to just think about what does a good health service look like for all. And one example I'll just give you about the small things being the big things. Is there anyone here that works in A&E? So show of hands, or there's one or two. I was recently with a very unwell relative in an A&E department, and actually the medical care was pretty good. But when I asked for a pillow for this elderly relative, I know you're all going to laugh, the answer I got was, we don't have pillows here. And I said, sorry, would you like to run that by me again? They said, no, we don't have pillows. They go up to the ward and they never come back. And I think I kind of obviously challenged that, and then that was followed by, what do you do for a job? Kind of thinking, why would I do that? But I've asked a number of my colleagues that work in A&E. I was going to do a blog on where have all the pillows gone, because everyone I asked said, "Oh yeah, that's how it is. That's how it is." So how simple is it to fix? You know, how simple would that be to fix? And that is my overwhelming experience that I talk about, not about the fantastic care that a relative had, but the fact that just something as basic as the dignity and comfort of an elderly person. So with that introduction, I'll tell you a little bit about where I work. How many of you have heard of NHS Resolution? Show of hands. Oh, that's very positive. That's good. We were traditionally known as the NHS Litigation Authority. We have changed our name with a focus specifically on resolution, and particularly on fair resolution. We have an indemnity system that supports the NHS across England, and our role is to manage claims on behalf of the NHS with the membership organisations, of which all of you that work in NHS organisations will be members of. If any of you are interested in how much your contribution is into NHS Resolution, that is on our website on fact sheet 5. It will tell you how much your organisation pays every year and how much is paid out for your organisation. The functions of the organisation are such that I don't actually work in the claims management part. I work in the safety and learning part. So my role really is to try and get everybody that works in the NHS to understand their role in what we can do in preventing claims and understanding what the claims are telling us about the level of harm in the NHS. And also, at the point that harm occurs, supporting organisations to put their arm around families and commit to apologise and to investigate what's gone wrong. And I'll tell you a little bit more about the service in a moment. We've got two other arms of the organisation. Practitioner Performance Advice was traditionally known as NCAS. Some of you may have heard of NCAS, which is around supporting doctors in difficulty. And we work quite closely with them, particularly around responsible officer events, in terms of feeding back to frontline clinicians so that they can understand the role of claims in terms of medical practice. And the primary care appeals is specifically linked to primary care. So the scale of the challenge. So that's the scary figures up there. So why do they matter? Well, they matter because every single organisation in the CNST scheme has to contribute on an annual basis so that we can collect in what we expect to pay out. So we have got to bring attention to this because I think, as we've heard earlier, this money could be so much better spent in the prevention arm, in making sure that we've got systems in place to prevent harm and really investing in areas that we know would start to tackle some of this. And you often see this pie chart. It just shows you the volume of claims that we receive on an annual basis. Since April, we took on GP claims as well. So that isn't reflected yet in that this is predominantly secondary care, mental health and community services. But what it will show you is the volume of the claims. They seem to switch between orthopaedic surgery and emergency care departments. We think probably emergency care departments, you see because the actual volume of activities is probably high, so we can see that they flip around. And then we see, I think as Peter mentioned earlier, we have 10% of the volume of claims representing over 50% of the costs sitting in maternity. So where do we start? So coming back to where I started is any of you that are interested in the theory of learning organisations is understanding what is a learning organisation and what are some of the principles behind it. Our previous Secretary of State has said repeatedly that NHS needs to become the biggest learning organisation in the world. If you look at the work of Don Berwick, it is absolutely the way to start to learn from harm. And when you hear people talk to you about why doesn't the NHS learn, it's something that we've really got to get better at. If we properly investigate and understand why things have happened, then we can learn and try and prevent it happening to others. The other part of learning organisations, and particularly if any of you are familiar with patient safety theory, is around safety 2, which is a kind of new way of looking at safety that absolutely focuses on where we get things right, learning from near misses, what goes well as the focus on what's not gone right. Partnership with families. Is Peter still here? Can't say. Oh, good. I'm really pleased that you're still here. Because part of learning organisations is not either or. It's not patients, families or staff. It's everybody is in this system together. And how do you get into a learning culture and stop the blame? And how can you be more open? So our principle really is understanding what families expect. And all of you will be, at some stage, carers, families, patients. If something's gone wrong, you expect somebody to apologise, to commit to learn, to stop it happening for somebody else, and have a compassionate response to understand it's actually very, very hard to write a letter of complaint. I don't know if any of you have ever done it. It's not something that people want to do lightly. And to signpost people where appropriate. So we did some research and we looked at actually low-value claims, which we sometimes call the frustration claims, is where families have got so frustrated that they feel the only way they're going to get an answer is to take a claim. And what we found actually was some of our own NHS staff were directing people down this route. Instead of taking ownership and actually saying, I'm going to commit and get the right person to talk to you and look into this, they were directing them down a route which kind of can become quite adversarial. Now, obviously, if a family is due fair compensation, of course they must be signposted to that process, and particularly to organisations like AVMA to support them. but that does not take away the responsibility of frontline staff to commit to try and support organisations in learning. One of the things that we see this happening, and some of this will probably resonate with some of you, is particularly between organisations. Sometimes you get one organisation criticising the previous organisation where someone's been treated. And the real kind of responsibility is not to tell the patient that the previous organisation was wrong, but pick up the phone with the previous organisation and try and resolve the problem. So the research demonstrated that NHS staff reactions were inadequate often, and that drove people into a process which actually can be incredibly difficult and stressful for patients and their families. So our document, if you don't remember anything else, this is absolutely always the right thing to do. It is not about, as Peter showed, does this meet the duty of candour or not? This is about if something's gone wrong, commit to apologise and investigate and do something about it. It's very linked to consent. And be very careful, if any of you are working in surgery, is that because something you've consented to has got a risk and something's gone wrong, it still means that it's the right thing to do to say sorry. About 3 years ago, my father had some very complicated heart surgery. We knew there was a 3% risk that he would die on the table. Fortunately, he didn't. But if he had have done, I would have expected someone to apologise and commit to look into it, not turn around and say, you know, well, that was the risk. We have to think about how that feels if you're the family. And, you know, often these cases may not be avoidable, but actually understanding that people have looked into it to just make sure is what families are looking for. So on to staff. What we found is we started to do some work with families and what good point of incident resolution looks like for families is it identified a need for us to also look at the staff. And when you speak to staff, they quite often will talk about what they feel, and sometimes they're asked to write statements or you know, give a view of what's happened, and then often they don't hear anything again, or they don't get that opportunity to have an involvement in apologies. They want to be treated with fairness and equity, and they also want to make sure it doesn't happen to someone else. They're part of that. And so signposting staff for support is really important. So that's how come we got to this point of saying, well, what could we do to help staff and help organisations look at a more equitable approach to when staff are involved in incidents? And the premise of this is not a focus particularly on staff, but it's on a premise that if you support your staff and you look after your staff and they work in an organisation where they have no fear of reporting incidents, and the way that they'll be treated and supported is they'll be far more likely to be open and transparent and candid with families and their patients, because it's the right thing to do. What we saw was a lot of inequity. If any of you are interested in the figures of the variation of disciplinaries around the country, and the different responses that happen, there are still organisations, if there's a couple of drug errors, people are pushed down a disciplinary process, and it will vary from organisation to organisation. So we got a lot of people in the room, a lot of stakeholders to say, well, what can we do about this? How can we produce some guidance to help organisations take a much more fair and consistent approach? So this is the document, and it talks about a balance of fairness, justice and learning and taking responsibility. It's not about not being accountable. It's about not seeking blame. It's around understanding what's happened, getting people able to openly talk about what's gone on, what they think has contributed, and understanding that they will be supported for doing that. The impact on staff where we don't get this right is very well documented. There's a lot of evidence about this. There's also evidence about huge inequity. If you look at the data the Royal College of Midwives produced in London a couple of years ago, 63% of the midwives that were taken through disciplinary processes were from BME backgrounds. And, you know, there's something going on in the way in which we approach a consistent approach to all staff, and that's being further backed up with the Fair to Refer guidance that's come out of the GMC recently. Staff that are involved in these incidents quite often, you know, I think somebody talked earlier around that, they sometimes never work again if they've been involved in a very serious incident. the way in which they're supported can make a difference. I've actually sat with a midwife at a fitness to practice hearing who was actually a witness, not the person in the conduct hearing, who was involved in an incident, and she's never worked again. She cried the whole way through the conduct hearing and has never worked again. You know, we have to support staff to try and help them and restore them and get their confidence back. What this guidance is not about is incivility and bullying. This guidance is about supporting people that have been involved in investigations. It is not about where people are rude, they bully, they cover up, they get defensive. It's around supporting people that have been involved in incidents. We get a number of claims that you'll see that in the documentation. So claims where staff have been harmed. So as well as the clinical negligence scheme, we also run a non-clinical scheme for staff. And you can see there that, you know, when you look at the categories of staff, what's happened to them, particularly when they've been under investigation, as it felt to them, and the impact on their mental health. The cost is huge. So suspending staff is a hugely expensive thing to do. It should be the absolute exception. It's very, very upsetting for all concerned, but also it's incredibly costly. What we say in the guidance is there are kind of 4 or 5 offers of frameworks that to be thinking about to use. Our absolute kind of gold standard preference would be the work that Merseycare are doing. I don't know if anyone's here from Merseycare, but they've really embraced the work of DECA, who starts with the premise of who is hurt, what do they need, and whose obligation is it to meet that need. And that is about putting families and staff in the same place. They look at a restorative approach, and they look at understanding exactly what's happened from all of the different perspectives and lenses. What we did in the guidance is we recognised that there was quite a variation in the approaches that take place in organisations to harm incidents. Are any, just a show of hands, in your own organisations, how many of you have a framework that you follow if staff have been involved in an incident? So kind of, actually quite a few of you. So there's a variation of, some people haven't got anything, and so having a framework is helpful. So if you look at the example 4, that's the based on a revised version of the James Reason decision tree. So that will ask some questions before you, it's a pause and think. If you've got someone involved in an incident, it's around thinking around, you know, was this member of staff, were they drunk? Was there substance abuse? Was there a deliberate act? Were they mentally or physically unwell? So you ask a number of questions to start with, and then you go through a number of other questions around, did that member of staff knowingly depart from a recognised, established policy or protocol? And be very careful around that, because sometimes our policies and protocols are not particularly workable. So I often ask this, and apologies if you've heard me say this before, how many of you in the room have ever written down an IT password? Go on, be brave. So you probably should all be disciplined, shouldn't you, really, because you breached your IT policy and your trust. So that's the point, is what do people do when policies don't work for them? They do workarounds. And they do more workarounds, and then that becomes normalised, and that's the way that people operate. And I've seen the number of those happen, whether it's around the second person to administer a controlled drug, you know, the locking of a drug cupboard, all kinds of things that people say, well, it's quicker to leave the drug cupboard on ITU open because we need access all of the time. So you've got these workarounds that go on, and then you have something suddenly will go wrong, and people will look at that. So those are some examples. If I were writing the James Reason tool today, I would put a final point on that which said, and what did that person do at the point of incident? You know, did they openly go and tell someone that they've had some harm error or not, or have they covered it up? Be very wary of any policies that talk about 2 drug errors and disciplinaries, because the likelihood is you won't hear about the second drug error. You know, it's really dangerous for patients to have that approach. And then there are others. So I think there's some people in the room from Barts who've got a sort of a modified checklist. And then you've got the restorative approach from from Merseycare, which is taking a very different approach. It's not looking at individuals, it's looking at the whole system. So all of those are in the document for you to have a look at, and what we would absolutely advocate is that you at least use one of those so that you've got a consistent approach. No matter what profession you are, what level you are in the organisation, there's always a consistent approach to the way you approach staff. This is a favourite slide of mine from Suzette Woodward, who I think it's really helpful to kind of talk about what that looks like. You need to be aware that very occasionally, and it is on very rare occasions, there may be an intent to harm, and they are very rare indeed. Mostly people are in the human error, under pressure, a number of other things happen, and sometimes people make some reckless decisions, sometimes for good reasons and sometimes for not good reasons, but understanding that. I just want to finish really with just something that came from my research, is we quite often hear in some of these reports around the world of hierarchy, and what we need to do is get rid of hierarchy and everything will be fine. Actually, what I found in my research, and this is just one example, is when I interviewed staff, and I interviewed a lot of staff, they actually want both. You know, it's not as simple as that. What people want is they want clear rules. They want to understand how to get things done and who is in charge. And, you know, and some of these particular wards, you know, it's very clear. So they have symbols, for example. The nurse in charge has a badge saying they're the nurse in charge. It's clear if you're a relative that you know who's in charge. And huge clarity of that. But at the same time, they wanted non-hierarchical behaviours. They wanted the executive team to be accessible. They didn't want to be having stuck in administrative processes and not being able to get decisions, having to not be able to talk to the right people. And one of the real features about this organisation was when their A&E was in difficulty and they were really up against it, what their executive team did, and this was consistent around all the people interviewed, was that they came down to the A&E department to say, what can I do to help? You know, and they just rolled up their sleeves to do whatever they could to help, not to come and say, you're missing the target, or take some kind of performance action about them. And so there was something about that. What they also wanted is, and this is very much a feature of this organisation, is people to take tough action on poor behaviour. And that's what they said. They felt that the senior team had their back. You know, they did not tolerate poor behaviour. They were very supported when incidents had occurred, and they had a very learning culture. But if people were rude, or they were, for example, one consultant was refusing to send copy letters to patients, that kind of thing was dealt with really quite harshly, that they absolutely did not tolerate people that did not follow the NHS Constitution. So my kind of message, I think, out of this is it's about behaviours rather than structures. It's about the way you are. And I saw something on Twitter the other day, just to finish, that somebody asked about a group in a conference about a show of hands of how many people have been bullied. And there was quite a show of hands. And then the second question they asked was, how many of you have bullied someone else? And there is something about looking in the mirror, about the way you're described, particularly the way junior doctors feel they can pick up the phone to seniors. And one of the features of the organisation I studied was that feeling that the consultants had their back, that they could pick the phone up and they felt supported, and that wasn't what was going on for their colleagues in other places. So other lesson, listen to junior doctors. They're moving around to lots of different organisations, and they've got a very good lens of what good looks like. So that's my kind of final slide, and that was very much what we found out of the research. Well-led is about balancing these four. It's not one or the other. You have to have commitment, but you also have to have some degree of compliance to standards. You have to have hierarchy, but at the same time, you must have a commitment to distributed leadership and shared ownership of the problems. So in conclusion, that's the document. Please read it. It's got a charter, which we've asked organisations to sign up, and I'm very proud to say that Peter from AVMA is jointly part of our charter, and it's about putting families and staff in the centre of our healthcare. So thank you very much for listening.